Okay, so next up we'll talk about what was formerly known as mood disorders, but now in two separate categories, depressive and bipolar. You'll hear mood disorders sometimes referred to as affective disorders. So you're looking at extreme disturbances in emotional states over a period of time. So I want to do these a little bit differently this time because I think it'll be more useful to go through some of these depressive disorders first, major depression and dysthymic disorder, because a lot of the other ones will make more sense after I do that. Major depressive disorder, or also known as major depression, clinical levels of depression, one of the things I want you to notice right off the bat is that you have to have 5 of the 9 symptoms for diagnosis. So you have to have, and notice the little asterisks here and here, you have to have either a depressed mood or be anhedonic, and I will explain what those mean in a second. You'll notice the 2 asterisks here, and that's if you have thoughts of death or suicide. What that means is essentially if you have that, you are suicidal in any way, then to get treated for depression, you no longer need to have 5 of the 9 symptoms. You could have fewer symptoms. So starting with depressed mood here, you'll notice like somebody could experience, say, a moment of feeling depressed. But this isn't just about having a depressed mood, even for just a day or two. It would be a severe or persistent depressed mood. Along with that, you'd have feelings of hopelessness and despair. So this is more than just feeling sad for a period of time. This is a persistent low mood, profound sadness, a sense of despair. A lot of people with depression actually may also have anxiety. Those tend to go together. But note that, if you consider valence dimensions of the emotion, it's a negative emotion, obviously, and it also is a low energy emotion. Anhedonia, on the other hand, is just this disinterest in social contact, lack of pleasure in social situations, an extreme social withdrawal, just sort of a lack of caring about things. I think where people in general might be quicker to recognize somebody who's experiencing a depressed mood, that complete withdrawal, lack of care for things, being anhedonic, is also a symptom of major depression. Other things you'll notice is that there's often a change in weight, so there's weight loss or weight gain. And if you think back to behaviorism, like food is a primary reinforcer. So I tend to, and just as a rule of thumb, not in all cases, but view weight gain as at least somebody is making an attempt to feel better, even if it, like, in the long term fails. They have this moment of, eating this pint of ice cream to make myself feel better. The weight loss, I think, concerns me a little bit more as a general rule of thumb, just because I wonder if you're doing anything to fight the feeling at all, because food is like the easiest source of feel-good, albeit a temporary feel-good. You'll also notice that with major depression, there's often sleep disturbance. So you could have insomnia, which would be an inability to fall asleep, or to stay sleeping, or hypersomnia, where you spend an excessive portion of your day sleeping, way beyond what would be appropriate and healthy for you. Psychomotor agitation or retardation. So psychomotor agitation would be like a nervous movements and energy, or sometimes like twitching or moving when you don't mean to. That psychomotor retardation would be that slowing down of thought processes, a reduction of physical movement in somebody. It can cause actually a visible slowing of physical and emotional reactions, including somebody's speech and their emotional affect. You can also see, fatigue, which kind of makes sense if you look at the sleep issues, inappropriate and disproportionate guilt, a poor concentration and inability to focus on what needs to be done, and again, that thoughts of death or suicide. So just a few more things I want to explain here. One is this is about twice as common, actually mood disorders in general, about twice as common in women than in men. And really one of the reasons why people think that might be is that women tend to, if something happens, women tend to have a more vivid recall of specific details, where men, if you ask them to report what happens, will often give you more of a vague description of events that took place. Now, I know that that's generalizing, but statistically, it seems to be mostly true. Another reason why you see these issues a little bit more, or a lot more, I guess, in females than in males, has to do with this, again, this sort of nature, statistically speaking, not 100% speaking, where women are more likely to think about things a lot and men are more driven towards acting on something. It just so happens that the actions can be the very thing that moves you out of depression. So to clarify, obviously if somebody is suicidal, that's a bad type of action, which is, we also talked about the gender differences in rates of suicide as a result of that. But if you were to treat depression, or let's just say if you were depressed, right? So if you were depressed, clinically depressed, one of the things that depressed people often do is remove things from their life. So they stop hanging out with their friends, they stop going to dance events, they stop doing stuff. And you really don't want to, do that. If you're depressed, those are the very things that actually keep you healthier. So when you start pulling things from your life, you start to lose the pleasurable experience and stuff. I also want to note that, so if you get treated for depression, one of the things that they might do in a hospital, and I think that this would surprise you, is they're not, if you're hospitalized for being, say, suicidal or depressed, right? You're in a hospital, you're not sitting there in therapy, like individual or group therapy all day. It's not like that. You're going to be engaged in a lot of activities. So you might be doing sports and art class and music class, that sort of thing. The very things you took from yourself because you were depressed, someone will help you to put that back in. Now, obviously, therapy would also be part of it. But the bigger picture is you need to include things that feel good. It's really important to do that. And if you are battling with depression, that is not the time to ask yourself whether or not you feel like doing something. You don't want to be depressed, then you've got to push ahead with your plans. And one last point I want to make here, in the DSM-4 TR, the depressed mood, it had to be for no apparent cause. So obviously if you are bereaving the loss of someone, there's a normal period of bereavement, and it wasn't formally classified as depression. But if you were really struggling or it was going on for too long, it could certainly, seek therapeutic help for that. They used to have V codes for that. But now the depressed mood can be related to something like bereavement. The next disorder here is dysthymic disorder, or dysthymia. And what I want you to notice, a few things here. You need 2 out of 6 of the symptoms for diagnosis. This one here you have to have. So this is a low-grade depression for the minimum of 2 years. Outside of that, a few things here. Poor appetite or overeating. So again, you'll see that weight loss or gain. Insomnia or hypersomnia, very similar to depression. Low energy or fatigue, same thing that you'd notice if you look at valence dimensions with emotions. Low energy, bad mood, right? Low self-esteem, poor concentration or difficulty making decisions, and feelings of hopelessness. What you'll want to note is that that suicide is not a threat with dysthymia. You want to kind of see this as, like I said, a low-grade depression, but it's a long-term thing. And often when somebody's dysthymic, when you're interacting with somebody who's dysthymic, you tend to bring the mood down a little bit. For everybody, there's something about them that doesn't kind of recharge your batteries, if you will. They kind of they're low energy, and that can affect the people around them. It's not actually uncommon for people who are retired in some capacity to be experiencing some level of dysthymia. And please, that is not to suggest that people that are retired are dysthymic. It's just that they're at a greater risk. And the reason is this, because if you look around, when you're in high school, college, whatever, there's people around, there's things to do, there's activities, there's whatever. And that sort of slows down as you get a little older. And when you spend your career doing something, whether it's, working at a business, school, staying home and taking care of the family, whatever it is that you're retiring from, when like the kids are grown or you retired and you have that like complete removal of responsibility, in that manner, in the way in which you have become accustomed, you have to kind of put something else in its place. You remember that whole idea of like, I need a certain amount of reinforcement. I need a certain amount of feel good in a day. And having a schedule helps towards that. Even if the schedule itself seems stressful, it actually helps. So now going back to this list, we've talked about major depressive disorder. We've talked about dysthymic disorder. So looking at double depression. Double depression would be a case where somebody who is dysthymic, clinically dysthymic, has a depressive episode where they may or may not become suicidal. And disruptive mood dysregulation disorder is actually a childhood condition of extreme irritability, anger, frequent intense temper outbursts. It goes beyond just being a moody child. It's severe and it impairs their ability to function in their normal life. This disorder was actually created in the new DSM-5. It was to kind of replace those people who had been previously diagnosed with pediatric bipolar disorder, despite not having the presence of a manic or hypomanic episode, which I will explain. So this was meant to more clearly describe the outbursts and the need for clinical intervention without mania. Then we have premenstrual dysphoric disorder. This is a health problem that's similar to PMS or premenstrual syndrome, but it tends to be more serious. It causes severe irritability, depression, or anxiety in the week or two before a period starts, and the symptoms kind of clear up about 2 to 3 days after the period starts. This is very frequently treated through like medications like birth control or SSRIs, cognitive behavioral therapy, physical exercise and stress management, that sort of thing. And the last two here, substance medication-induced depressive disorder, would be exactly that. So a major depressive disorder that is brought on at the start or cessation of a medication or drug. And depressive disorder due to another medical condition would be experiencing the symptoms of depression as a result of some other problem. It could be diabetes, arthritis, back pain, certain types of cancer, metabolic conditions, autoimmune conditions, etc. I want you to note with this entire class of disorders is that it can't be better explained by another type of disorder. So if you're seeing the symptoms of major depression or dysthymic disorder or what have you, if somebody is, has a substance abuse problem, then that's really the diagnosis, and this would have to be ruled out later. For bipolar and related disorders, I'm going to do the same thing. I'm going to explain what bipolar is, and then I'll go through this list of looking at the difference between bipolar 1 and 2, cyclotimic disorder, etc. In bipolar disorder, a person has at least one manic episode and at least one depressive episode or mixed episode. That would have to be present. They would, for bipolar, they would have to have had a manic episode where they have 3 out of 9 minimally of the following symptoms. And before I read off the symptoms to you here, I do want to say that the suicide rate is pretty high. It's between 10 and 20%. And a lot of that has to do with the severity of the depression after a manic episode. Now, these manic episodes can last a few days to a few months if it's a full-blown manic episode. So looking at the first thing, inflated self-esteem or grandiosity. So this idea that you will be rich and famous, or you're going to save the world, you're going to fix the world's problems on some front. Decreased need for sleep, so you feel rested after only about 3 hours. So somebody in a manic episode doesn't need the same amount of sleep that everybody else. They feel that they don't. They can keep going. They can push way past. They've got to spend all night doing all kinds of stuff and then continue the next day doing the same thing. They're more talkative than usual, or they feel a pressure to keep talking. That pressured speech where nobody can get a word in edgewise. So somebody in, say, a manic episode, might come in and be like, let's say you have it's a table tennis club, and so there's a ping pong table there, and somebody in a manic episode might be like, oh my God, you guys are playing ping pong. Oh my God, I should make it my own ping pong table, and I'm going to make a net, and I'm going to make it the best thing, and I'm going to be the best one in the world. I'm going to order all this stuff, and they just keep on going with all of these ideas that they have. And nobody can kind of react to it. There's not really a chance for somebody to get a word in there. Next, you'll sometimes see this insomnia or hypersomnia nearly every day. There's a book I read a number of years ago. It's called Rat Girl. And the girl in the book, when she was having a manic episode, she would actually go to people's homes. I kind of got the sense it was in a rural area, although I'm not sure. Maybe suburban, I don't know. But she would go to people's homes and swim laps in complete strangers' pools. And if somebody turned their lights on or somebody was home, it wasn't a possibility, she'd go to the next pool she could find. And she would spend most of the night doing this. Again, you will see that psychomotor agitation or retardation, that kind of like nervous energy or twitching, or the slowing down of thoughts and what you're able to do there. Flight of ideas or subjective experience that the thoughts are racing. So it kind of, you saw the pressure to keep talking sort of thing, that very fast, very quick, moving from one thing to the next. Distractibility, so attention is too easily drawn to unimportant or irrelevant external stimuli. An increase in goal-directed activity, either socially, at work, or school, or sexually. Somebody having a manic episode might have enormous ideas about what they can do, what they can get done, what they will involve themselves in. And so they could, in a very short period of time, have a lot of sexual encounters. They can spend an insane amount of money, rack up all of this debt because they've got this plans. They're going to say, like, be this, the best DJ ever that ever was. And so they're going to, borrow some credit cards and max them out, or use their own and max them out, to get all of this equipment because they're going to be the best DJ ever, and they're going to have it all, whatever, these plans. And at some point, this manic episode is going to end, and they're going to be left with whatever the damage was that they did based on the activities that they engaged in. So was it like tons of sexual partners? Was it a lot of spending? Was it drugs? What have you? It may have felt good for them to do it while they were in the manic episode, but they often can have a lot of damage that they have to fix afterwards. Damage being, it could be financial, it could be physical, it could be in their social world. And that brings us to the last point there. So this excessive involvement in pleasurable activities that have a high potential for painful consequences. So again, like, giving away money, which might feel very pleasurable to do, like they're standing on the side of the street giving $20 bills away to total strangers, might feel good at the moment, but the consequences of not being able to pay your rent later on are going to be real. Engaging in unprotected sex, perhaps with multiple partners, dealing with the consequences of that later on, that's going to be real. I am really hoping that what you're understanding when you hear the description of a manic episode and you hear the description of a depression or a major depressive episode, that you understand that if somebody is bipolar, they are not just being moody. I think that gets thrown around a lot, like, oh, I'm so bipolar. No, we should also stop throwing around psychological diagnoses like that, but that does not mean that you're moody. This is pretty extreme. So looking at the difference between bipolar 1 and bipolar 2, in bipolar 1, you would have a full-blown manic episode, like I described on the previous slide. In bipolar 2, it would be considered a hypomanic episode. So somebody having a hypomanic episode would be somebody who is like persistently, for at least 4 days again, 4 consecutive days, with this very elevated mood, feeling very expansive, or extreme talkativeness. They're extremely excited. They're extremely irritable. They're extremely distractible. They have a reduced need for sleep. But none of it hits the level of a full-blown manic episode. With cyclotimic disorder or cyclothymia, you don't have those big manic episode, a full-blown manic episode that you would see in bipolar 1. And you don't have the full depressive disorder that you would see in bipolar 1 or bipolar 2. So what you have is hypomanic episodes, similar to that of bipolar 2, but often longer lasting, or hypodepressive, so not meeting all the criteria for a depressive disorder. In bipolar, the depressive disorders tend to be extreme. In cyclotimic disorder, it's all hypo, it's all less than. It's not a full manic episode, not a full depressive episode, as compared to a regular depressive episode or a regular manic episode. Sometimes in cyclothymia, you could have rapid cycling cyclothymia. And lastly, here are some of the causes of mood disorders, or the potential causes of mood disorders. So one, biological factors. You could have a decreased amount of gray matter. Granted, this is a sort of chicken and an egg issue here. Decreased frontal lobe functioning, specifically the left frontal lobe, which is associated with positive moods, and those are going to be less activated. In severely depressed patients, that frontal lobe might even be measuring about 7% smaller than it should. There is an imbalance of certain neurotransmitters, so serotonin would be scarce during depression. Norepinephrine would increase arousal and boost mood, so it would be overly abundant in mania and scarce in depression. Dopamine, which would be scarce in depression. Remember, dopamine is another feel-good neurotransmitter. And all of these neurotransmitters are going to affect arousal, hunger, sleep, and wake. So drugs that affect these neurotransmitters will help to reduce depressive symptoms. From a genetic perspective, if you look at twin studies, if one identical twin has a mood disorder, there's about a 50% chance that the other twin will also develop it, but it's not 100%, which would suggest that environment plays a role, right? But also consider this, relatives also have a tendency to have similar environments. Looking at the evolutionary perspective, this would suggest that depression may be an adaptive response to a loss, and it helps people to reassess their goals. Looking at psychosocial theories, you have cognitions, learning, and relationships. So what is the thinking associated with being depressed? What has been reinforced? What do the relationships look like? In your psychoanalytic view, you're taking anger and you're turning it inward against yourself, usually due to relationship or attachment loss. They would say that in the psychoanalytic perspective, that this anger comes from the feelings of rejection or withdrawal of affection. The humanistic view would suggest that depression is a result of an overly demanding self-concept, especially when positive growth is blocked. So you have this idea that you should be something, and yet for whatever reason you cannot reach that because there are obstacles in your way. Learned helplessness, this is that idea that, so remember Seligman did those research on animals, or that research on animals. He said that this learned helplessness results from when animals are subjected to pain that they cannot escape. The animal becomes helpless and no longer attempts to get out of the painful experiences. Even if there's an option to get out of them, they stop trying. So if you feel that you can't change the situation for the better, you become depressed. Individualism makes us increasingly prone to depression, so you're not seeking outside support. You feel like you should be able to handle it on your own. And then this idea with learned helplessness that bad events are, in the view of the depressed person, stable. So they think it's going to last forever, that they're global and that they will affect everything I do, and they are internal. They're all a result of what I do. That would be kind of an example of bad attribution, right? And then speaking of, looking at the cognitive side, you look at attributions, are you explaining things in your environment in a way that makes you feel good, or are you explaining things in your environment that make you feel bad? So something bad happens, is it because you are a bad person, or is it because the situation was bad? And then remember cognitive distortions, like shitting all over yourself. I should be able to do this, I should be able to do that, that sort of thing.